Today's topic is healthy communities, immigrants helping immigrants access health care. Whether for patients or internationally trained healthcare workers, the question is, how can we create more equitable access to health care in urban communities? How can we connect newcomers to the resources and services they need for well-being and for a productive contribution to their new communities? In the next hour, we will learn about success from San Francisco, United States, and Hannover, Germany, that address the need for linguistically and culturally competent health services in underserved communities. First, I'd like to ask you to join me in welcoming our first speaker from San Francisco. Jose Ramon Fernandez Pena is the founder and director of the Welcome Back Initiative, which works to close gaps in immigrant access to health care by connecting internationally trained healthcare professionals to employment. Hi, Jose Ramon. Welcome to the Learning Exchange. I'll pass the podium to you.
Good morning. Hello from San Francisco. I want to start by giving you a little bit of a background as to our situation here in San Francisco. And I'm joined in this process by my colleague Chris Mason, the director of the Welcome Back Center in Seattle. San Francisco, as many of you may know, is a small city on the West Coast in California. It's only 121 square miles. And if you see here, about 37% of the population of San Francisco is foreign-born. Moreover, over half of the population in San Francisco is made up of the so-called minorities. So San Francisco is a minority-majority city. I'll have you notice as well that Latinos in San Francisco represent 14% of the population. In about 46% of the households, almost half of the households in San Francisco, the families speak a language other than English. And 37% of the nurses in this area are from minority groups. But going back to the reference about the fact that 14% of the population is Latino, only 4% of the nurses are Latinos. This is also true for other minority groups. The underrepresentation of minority professionals in the health workforce has been documented through several studies with a direct relationship to health disparities, at least in the United States. I'm sure this is the case in some other countries as well. So in 2001, we started the Welcome Back Initiative with the idea of connecting these populations, these immigrants that were health professionals in their countries of origin, came to the United States and ended up not working in the fields that they were trained in. On the other end of the spectrum, we found that the health sector was desperately looking for ways to better deliver services to the ever-growing minority populations. So the Welcome Back Initiative intention is to connect community assets with community needs. We started out in San Francisco, and we're currently located in 8 states. We have 9 centers, and if you see in this map, the states represented in blue are where we currently have Welcome Back centers. One of the items that is often forgotten is that immigrants come in all colors and shapes, and many of the immigrants we see in the United States are highly skilled individuals. We tend to think of immigrants as communities in need, and we often forget that these are communities that bring strong assets that could be nurtured and in ways that may enable them to become contributing members of society. For example, you see here that 27% of the people that live in the United States that are foreign-born bring with them higher levels of education than the local population. This is true in the very areas where we are working right now. So the notion that immigrants are always populations that need some kind of repair or some kind of training is not necessarily true. Before the creation of the Welcome Back Initiative, there was no single place where these individuals could go and find the necessary information or the necessary resources that would enable them to return to the health workforce. The first thing we did when we started our work was to go out to the appropriate entities and find out what were all the licensing processes that individuals that had a foreign education needed to go through in order to become licensed in the United States. We became that repository of information, and up to date we have served over 11,000 people from 151 countries. We also advocate for policies that recognize the contributions that immigrant health professionals make to the U.S. health workforce and to remove artificial barriers to access to educational programs. We also work with employers to better understand their needs and to prepare our participants for success in the health workplace. In this chart, what I'm trying to tell you, I present you 6 of our participants, and we have physicians, nurses, pharmacy techs, and this is how they come through our program. A participant can come in through many points and may need different pathways. For example, the first person here, Rima, may come to us and her first need may be, for example, to get her transcripts from her country. Joaquin may need time to study for the medical licensure exams. Elda may not be sure what her options are, as relicensing as a dentist is a very expensive process in the United States. Chetan could sit for the licensure exam right away given his level of education, while Mahmoud may need to improve his English. William may need to consider alternatives to his career. So the way we work with these individuals is we developed a strategy that is completely personalized to their situation, to their needs, to their financial status, to their immigration status, to whatever may be the specific needs that they have. Our model is flexible enough that allows us to not only take participants in, but track them throughout the process that they may have to go through in order to achieve their professional goals. The flexibility of the model is one of the items that has made it replicable in other places. It's not a one-size-fits-all. It's not that all participants come in through the same door and come out the same door. For example, in this very complicated chart, what I want you to notice is not all the little details that a foreign-trained physician would need to go through in order to relicense in the state of California. But from our knowledge about what is the process, we can present this information to the participant, and if they decide that this is not an option for them given their current situation, we then have the opportunity to expose them to alternatives to their original career. For example, the physician that feels that she is too old to go through all this process but has a strong background in research may want to pursue a career in medical research. Or the physician that was always involved in primary care and preventive medicine may choose to pursue a master's in public health and then return to work in the community with that new degree. So the attention to the details of each of the licensing pathways has enabled us to provide this very customized level of counseling to each one of our participants. One of the common barriers that we encounter in working with them is the fact that the command of the English language is oftentimes a barrier for them to achieve their goals. And while there are many courses of English as a second language offered, most of those courses tend to be long. They tend to go anywhere from 3 to 5 years and are oftentimes focused on basic survival skills. That's why we created an accelerated, health-focused ESL curriculum, English as a second language curriculum for this population. And we developed this fairly complex curriculum with strong input not only from educators and health professionals, but from the participants themselves to better understand what were some of the pieces they needed to have in order to be successful when they are working in a multicultural environment. You may notice that we have a full module, Module 5, where we only talk about intercultural communication in healthcare. In our societies, which are becoming more and more multicultural, it's important to recognize that different values and beliefs and ways of approaching men, women, age, professions may come into play as they work in the health sector. As of earlier this year, excuse me, As of January, we have served 10,900 participants from 151 countries. About 70% of them have engaged actively in some process that would lead them back to a profession in the health workplace in the United States. You see that some of the outcomes here, let me focus on the third one, physicians accepted into residency training programs. All foreign-trained physicians that come to the United States, regardless of what profession they held in their country of origin, must go through a residency training program. And we have gotten 87 of them into residency training. This is not a big number by all means, but what this speaks to is the return on the investment, because the education of any one of these physicians would cost approximately $250,000 in the United States. These are dollars that we did not need to spend in training them, but rather we've honored their training, and we have saved in that way $18 million just in these 87 participants. Their income increases exponentially once they come to us and through us, and their increases are up to 255% of the level they had when they came to us the first time. On average, we spend a little over a year with each one of them from the time they come in to the time they come out the door with a new profession or with their original profession validated to work in the United States. The model, as I said earlier, has been disseminated into 8 other cities in the country, and one of the ways we have done this is by developing a very focused toolkit to support the dissemination of the model and the replication in new centers. We spend 3 days training new centers on the how to deliver the services, how to work with our database, data collection system, our electronic records. And we do about 6 months of planning with the new entities that are interested in replicating, in really assessing the environment where they want to take the Welcome Back model, finding key partners, identifying opportunities, identifying threats, identifying potential supporters, establishing partnerships with educators, regulators, employers, in order to ensure that when we open the doors, the place is ready to go and start receiving participants and providing services. In the United States, each state licenses its health professionals, and one license does not necessarily carry to the other state. So it's imperative that we understand what are the local needs and what are the local requirements, because a nurse in California may not necessarily be able to work in Texas without going through some process. And through those partnerships, we're able to replicate the model successfully. What we have learned in this process has been that your participants, or the participants that come to us, will bring a wealth of professional experience, but will also bring a unique set of needs and barriers. And I want to emphasize the fact that this is not a one-size-fits-all approach. Individuals will always be individuals, and their particular circumstances will determine very clearly what are valid options for them at the particular point in time when they come to see you. We have also learned that it's very important to approach the dissemination or the implementation of a new center in 2 phases. We really want to emphasize the planning phase, without which we have also learned the hard way that the program is harder to launch, and having everything in place before we even announce to the world that there's a new Welcome Back Center. We have had the experience where there was a press conference announcing that a center was opening before any of the services were in place, and the place became completely overwhelmed in the first week, and the participants or potential participants became frustrated because they were calling a phone number where there was nobody to answer their questions or their needs. So the fact of approaching the project in 2 phases is a very important piece for the success. With the training and support of the Welcome Back Centers, we have been able to replicate this model, and we continue to work with each one of the centers over the life of the program through conference calls with the center's directors, the educational case managers. The whole groups have their own support networks in the national agenda, and we continue to share materials, experiences, opportunities for funding, opportunities to work collaboratively on advocacy issues, replicating new curricula that one center may have developed for another. So the support of the network enables the network to continue to grow and to continue to be successful. And with that, I am going to stop now.
Thank you, Jose Ramon, for that excellent presentation and for sharing your experiences at the Welcome Back Initiative with us and your success in creating opportunities both for the internationally trained professionals, but also for creating such a flexible model that can be studied and replicated by others. And we're going to hear about, and now we're going to move over right away to another health care model, another good idea from Cities of Migration. I'd like to introduce Ramazan Salman, who is the Executive Managing Director and co-founder of the ethno-medizinisches German Zentrum in Hannover, Germany. Since 1990, Ramazan has spearheaded a system of nationwide networks called MIMI, Migrants for Migrants, that trains cultural mediators to promote health literacy and improve health outcomes for immigrant communities. Welcome, Ramazan. I pass the mic to you.
Hello, Kim. Hello, Jose. Hello to everybody from Hannover. In my short presentation, I will deal with 3 topics. First, I would like to shortly introduce my organization. Then I will present MIMI, our key technology for healthy integration with transcultural mediators. And finally, I will give you some examples of how MIMI works and how it can be transferred to other sectors. So, MIMI has originally been developed to face social inequalities and barriers for migrants in the access to health and social services. On slide 1, you can see the challenges we are facing. Socially, inequality affects health risks. Migrants are overrepresented with regard to accidents and diseases like obesity, diabetes, and etc. Migrants are less informed about the health system, methods of treatment and prevention. Language and cultural differences are barriers to public and private services, and access barriers affect integration-related decompensations and diseases. Migrant employees are underrepresented in health services. To solve these problems, we developed the MIMI model of transcultural mediator training. MIMI stands for Mit Migranten für Migranten, which is translated in with migrants for migrants. It is a system for health education and health campaigns conducted in more than 15 languages to date. In 2007, WHO identified MIMI as a best practice model for the inclusion of socially marginalized groups. We created MIMI because we want to build networks addressing migrants' health and education, and to design, conduct, and self-evaluate community-based prevention campaigns with transcultural mediators, to train socially well-integrated migrants, provide support to those less well-integrated by informing and educating them about health and prevention, and motivating them to become more integrated, to empower migrants through participative processes, and to support migrants developing positive coping strategies. The MIMI program consists of 6 modules. The first module is training of mediators. The second is creating of health guides, multilingual campaigns, evaluation, public relation, and last but not least, empowerment and national networking. Once the project goes ahead, well-integrated, bilingual, interested migrants are recruited to be trained as mediators and attend the 50-hour course. Once certified, they are paid to develop, organize, conduct, and evaluate, communicate education sessions on health or social topics in their communities. MIMI follows 3 core principles. First of all, we aim to empower migrants by working with them, not just for them. Secondly, we provide training to enable mediators to conduct and self-evaluate community group. Finally, I believe that It is important for migrants not to see ourselves as the victims of our situation. Normally, migrants have become experts in dealing with the situation we live in. Slide 4 visualizes how the intersectoral conception and coordination charges the MIMI mediator system. It illustrates the results achieved by MIMI. MIMI is now being conducted in 15 languages in 52 German cities and 6 European countries. Now coming to MIMI, which has a positive and sustainable effect on all social groups and institutions involved in the intersectoral approach. And the most important are that migrants become more motivated and empowered, natives gain a positive image of migrants regarding and approaching them as active members of society, public institutions are sensitized, gain access to migrants' community, and treat migrants as equal partners. Private enterprises recognize through MIMI diversity as market advantage and employ migrants. Now coming to transfer of MIMI to other fields and sectors. MIMI goes Europe. The transcultural mediator model is used internationally in the AIDS and Mobility Europe project, which is financed by European Union. We are the leading partner for the European Union. I am the official program director of AIDS and Mobility Europe. We are carrying out AIDS and Mobility currently at 6 sites in Copenhagen, Tallinn, London, Rome, Istanbul, and Brussels. After successfully recruiting about 20 mediators in each site, community sessions are now underway. So far, 153 community sessions have been conducted and more than 2,000 young migrants have been reached. The core activities of AIDS and Mobility project have been implemented and it is now entering its evaluation phase. We therefore conclude that the particular transcultural mediator approach based on MIMI can indeed be successfully transferred to 6 different sites across Europe. This means that HIV prevention can benefit a great many more countries and settings in the future. MIMI goes financial too. In 2008 and 2009, we have conducted successfully a MIMI Finances, which was financed by Levi Strauss Foundation. We trained migrants as financial mediators to help fight lack of financial literacy among migrants. We recruited socially committed people with privileged financial or business knowledge recognized in their ethnic community. The topics that were taught were private financing, planning, calculating expenses, avoiding debts, self-employment, etc. The curriculum covered also educational and psychological aspects of group teaching and presentation skills. Our achievements were that we trained 15 financial mediators who conducted 45 information events, reaching more than 800 youth, women and men with an immigration background. On slide 8, we have another example of how adopting MIMI in the corporate sector. We have adopted the MIMI model in the context of in-plant health management of migrant employees at BMW, which is a car production factory in Germany. The model was controlled and evaluated by BMW car factory and Munich City drainage company. The model combines MIMI with well-established strategies of staff management and transferred it into the field of intercultural team management. The model is based on intercultural training of intercultural management skills and training of staff with or without immigration background as intercultural health mediators. We did this because it's not possible to go in a big factory and say we want to do only something with migrants for migrants. In that case, we did it together with the Germans and we gave with the migrants services to the Germans too. The main objective was to find committed employees without migration background and some without migration background, and to train them to navigate colleagues through the in-plant care services when help is required. A further module was an intercultural multilingual guidebook on work environment with the title Health at the Workplace. We had excellent results. through the utilization of the program tools, the structures of health management and workplace safety in companies have become very effective and sustainable in their outreach to migrants and in health production. Mimi Goes Transethnic summarizes our work and health project, which applies the model to fight the health issues caused by long-term unemployment. In a 40-hour course, state-run job center staff were trained as health coaches. The goal of this project is to help develop health literacy among long-term unemployment people over 50, which means that we do behavioral prevention with them. To develop health literacy among professionals working in public labor administration. Taught topics were basic health and public health, psychological and group dynamics, nutrition, physical mobilization, drug abuse, etc. We get beautiful results too. Structural or relational prevention has led to a dismantling of prejudices in institutions towards jobless clients. Long-term unemployment show more trust and differentiated perception of the job centers and staff in help building empowerment and self-esteem. On the whole, one can observe the MIMI model does not only work with migrants empowerment, but can also be applied and implemented in trans-ethnic context to overcome social exclusion and discrimination of possibly any kind. At the end, finally, I want to present you our 5 most important lessons to learn from the MIMI experience. The first is, do not reinvent the wheel. Make use of the best practice approaches. Transfer, adopt, and expand services, standardize evaluation, and quality assurance. Integrate feedback and evaluation in monitoring program outcomes. Diversity and assets approach, which means benefiting from migrants' resources through access to their communities and letting them make use of their bilingual and multilingual skills. And finally, think big. Models developed for migrant communities can be adapted to contribute to the economy and society of the host countries. At the end, I think I have 1 minute. I have to say that I haven't given you much of data. I wanted to present you the program structure and the program concept. But in this program, in the last 5 years, we organized more than 4,000 community group sessions. And we have now more than 1,800 mediators all over the country in more than 52 languages, or from more than 50 countries and cultures. And we have a network on organizations which are cooperating with us, and these organizations are more than 400 organizations only in Germany, which are organizations which we work together very seriously. So it is in Germany the really biggest integration program which is dominated by an organization which is led by migrants themselves. Thank you for your interest. I'm looking forward to your questions.
And thank you very much, Ramazan. That was a tremendous presentation, and we admire enormously the both the flexibility and the inclusivity that the particular approach that you've taken creates for the immigrant communities and other populations as well. We're going to move towards the question and answer period now. We've concluded the formal presentation part of our webinar. We've got, before we open up the question and answer, we're going to have a little fun, and it'll help us sort of straighten out back here. We've put, after hearing from our presenters, we want to ask you, the audience, for your views. So we have put a poll on screen and ask you to cast your vote. You have about 30 seconds starting now to tick off the answers. In your opinion, Improved healthcare for immigrants includes healthcare providers who speak the same language, access to healthcare insurance and services, health promotion campaigns, cultural sensitivity training for health professionals, or non-Western options for medicine. You can choose as many as you apply, and we'll just give you another 10 seconds or so before we post the poll. So far, we've got very good. We've got almost half the audience has now responded, and we're going to publish the poll now. And what's interesting is how even actually the distribution of these results are. Nevertheless, people have decided that the top three indicators are cultural sensitivity, training for health professionals, access to healthcare insurance and services, and health promotion campaigns targeted to immigrant communities were the top three areas of effort that our audience identified. Thank you very much. We're now going to go to our questions from the audience. I'm going to invite to join us for the live portion of our session Chris Mason in Seattle, who's the director of the Puget Sound Welcome Back Center there. Welcome, Chris. Please continue to submit questions to the Q&A while we take our first question. And that question today is we'll start here. Both the initiatives that were described today create clear and significant benefits to immigrants, whether they're patients receiving better health care or health professionals being integrated into suitable employment. But these programs, both these programs are also enriching host communities. So we've heard a little bit about this already from Ramazan, but I'd like to ask both of you to comment briefly specifically on how your work is informing healthcare systems in Hanover and San Francisco in ways that benefit the entire community, and also influencing the larger health policy frameworks that govern your work. And maybe we'll start with you, Ramazan.
Yes. For the mediators we have, they are in the majority key persons of their cultural communities. So if we train them, it's not very difficult for them to reach their own communities. They are going to mosques, they are going to cultural clubs, to coffee shops, to schools, and the best way to reach and to find the people is if you have the model to inform them mouth by mouth. Oral information is the best. We tried with information in newspapers, by brochures, but this didn't function. So we have a best experience if the people are going and speaking, for example, with the imam and organizing trust. Then the imam is saying to his community, come to the session in my mosques, and after that we have 100 people or 50 people. It's not very difficult. More difficult is to organize a network with the professionals and the institutions and the healthcare system. Because the migrant, if you speak with a imam 20 minutes, then he trusts and he opens the door. This is not enough for a general health service. You have to organize a training for the professionals. You have to make much of political works, and you have to give them much of trust by saying them which great system you have behind yourself. So it is more difficult to open the institutions than to open the migrant people. Before I began with this work, I thought the opposite. I thought it is very difficult to reach the migrants. But today I know it is very difficult to come into the majority-dominated healthcare organizations. And because of that, we organized let me say this at the end, we organized a political network in Germany, and we are influenced not the local policy, we influenced the national policy. And that was a surprising thing. As we influence the national policy, we get more success in the local sector. So it was not so difficult. Because of that, I said in my presentation, think big. It was not so difficult to influence the national policy. Before that, it was more difficult to influence the local policy.
Mm-hmm. Thank you. No, that's wonderful. Thinking big definitely has paid off in your case. And how about you, Jose Ramon? Would you like to comment on the ways in which your work is benefiting the larger community and the influence that we hope it can have on the health policy agenda in the U.S.?
Sure. I think that our programs, both Ramazan and ours, in so many ways facilitate immigrant integration into the fabric of society. And in so doing, in our case, for example, our participants' increase in income results not only in their own benefits, but benefits to the community. The tax base increases for the community where they live. The fact that these individuals can afford better housing and better schooling for their children results in betterment of the total society. In addition, it helps dismiss all the myths and misconceptions that many people have about immigrants, because if you marginalize this population, you never get to see their full potential. You never get to see them as peers. You don't get to see them as people that are as well trained as you are, or as capable as you are, or more capable than you are. So really it levels the playing field for all communities to play as equals, and eventually I would think the ultimate goal is immigrant integration.
That's excellent. Thank you. We have a question. Ramazan, you addressed some of this question in your own remarks, so we'll address this question to Jose Ramon about how hard it is to get the word out to newcomer health professionals, how you've identified your target population and what strategies you've got to describe.
It's a very interesting question, because we have not. The communities have found us. About almost 70% of our participants have come to us through word of mouth.
Okay.
Typically in places where we open a new center, we have a press conference or some announcement that we're opening a center, and the word just spreads out through the natural networks. Informal networks are our main source of referrals to all our centers.
That's very interesting. So we have another question here again that speaks to the partnerships within the community. Anna Kim asks about barriers, and barriers and opportunities, I think we'll reframe it, to collaboration and community partnerships, and how you went about engaging, overcoming barriers and engaging the kind of collaboration that's helped make your program so successful. And again, Ramazan, would you like to start?
Yes. We have a concept for it, because we are present in 52 cities. So if I say we are present, then I say by the same time we are not able to be present there every time. And so we organized in every of these 52 cities, in the sites, a network of institutions for health and for the local institutions. So in every city we have a welfare organization, we have a NGO of a migrant community, we have the General Health Service representatives, we have the local integration services, and at the end, normally we have 8 such institutions who are sitting on a round table and who are working together to implement our program in their city. So for the sustainability of the program, it is very, very important that not we are every time identified as the leader of the program in the local site. We are only coaching the network in the local site to implement the program. Because by the same time, we learn them how to implement a well-organized, a successful integration program. And the second thing we learned about this concept is, if we say them do it together, then we learned that the first time they do it together. We were very surprised that every institution in the same city has its own concept, and mostly they are very different concepts. The one tries to go with health, the other one tries to go and to reach the migrant population with education programs, and the concepts are totally different. Nobody works together with another one. And in our last evaluation, we get a very positive reaction from the They said that first time they worked together, and before that they did not understood that it is important that the different institutional levels have to cooperate together to implement the program with evaluation too. And I think in 15 or 16 cities, a very important partner is the university, which evaluated the program in this site. And this is another point I saw, that it is important to include in this practical work maybe scientific organizations too. So networking has to be done, in my opinion, with a strictly concept.
So a wide, you throw a wide net across different sectors and groups. And how about you, Jose Ramon? How do you deal with community partnerships? What role does that play in your work?
Essential. We could not do what we do without partnering in very collaborative and respectful manners with the key players, in our case, certainly the employers who are the direct beneficiaries of the work that we do, even before the communities, with the regulators to ensure that we have captured all their needs and that we address all the requirements for licensure. We also have to work with, of course, the communities themselves. I think that understanding what our participants need and where they are, and in so doing, being able to look for the partnerships that will facilitate and enable their development, be it through community services such as childcare or legal assistance or housing assistance or availability of scholarships. Without all those systems of support, we could not do the work that we do.
I have one more question for you, Jose Ramon, because of, and I'll just address it, I think, to the Welcome Back initiative, because of the constraints around the cost of health care delivery. I would imagine those community collaborations are also important to your funding. And one of our audience members, Julia Chow at the Canadian Cancer Society, is interested in how the Welcome Back centers are funded.
Yes, each center is independently managed and funded. So each center has a combination of possible pots of money that could include federal grants or federal sources of funding, for example, through the Department of Labor or through the Department of Education. There's also a mix of local monies from the city, for example, from the Department of Health and Human Services, or from a series of funding collaboratives that exist in San Francisco or in Seattle. Employers are at times contributors to our work, either in kind. For example, our center in San Diego, its offices were donated by one of the big health networks down there. Sometimes employers pay for the offering of a particular course, for example, a nurse refresher course, or grants. We also get quite a bit of money from private foundations that are supportive of the work that we do. All this to say that we have mixed bags of what we call soft monies. Most of our centers are not hardwired into stable sources of funding. So one of the challenges that we continuously face is the need to find new money year after year after year to continue to do the work that we do.
Thank you. Now we're going to turn to a few practical questions that we've received. Ratna Omidvar of the Maitree Foundation in Toronto asks about the role that cultural sensitivity plays in the work of Mimi and of Welcome Back. And so perhaps you can take a turn, starting with you, Ramazan, about how your approach to the issue of cultural sensitivity in your work.
In the view of the professionals, which are mostly from the majority, cultural sensitivity is more important than from the point of view of the accessed migrants. The migrants are saying it is not necessary that they understand our culture. It is more important for us that they speak with us, they ask us what are our problems, and they communicate with us. And in my opinion, the cultural sensitivity is not so important like the discussion as the scientific world says. Because it is more important to learn how to reach the people, how to speak with the people. The idea of, if I know something about the cultural background of one of the hundreds of cultures which could be represented in our customers group, the idea of, if I know something about their cultural background, then I'm better prepared to work with them, is not a very functional idea, in my opinion. My opinion is to know something about the technologies, the concepts of how to reach people and how to analyze what is the need of people is more important. An example is, for example, when I speak with the majority-dominated professionals, for example, they say that in their opinion the needs of the migrants are themes like drug abuse, or AIDS, or anti-violence programs, and so on. If I speak with the migrants and ask them, what is your need? They say to me more women's health, children's health, how to reach or how to get an interpreter when I'm not able to speak about my problems and I'm going to a hospital. And what we try to bring, to build a bridge between both and to show that new ideas are necessary, not only the old idea of cultural sensitivity, to learn more about the other side than to believe in your own views.
And Jose Ramon, would you like to comment on the role?
I totally agree with your comments, Ramazan. I don't personally like the notion of cultural sensitivity. To me, it's something more around if we needed to label it, it would be cultural humility. So the understanding that I am not the holder of the truth. So are we a sensitive, culturally sensitive program? Of course we are, but not in a condescending manner, but in a respectful manner. I think that the approach of starting from a place where I don't know who you are or what you believe in, and unless I start from a place where I'm open to hearing your needs, to hearing why your particular situation enables you or does not enable you to pursue your professional goals, I have to be able to check out my assumptions. I need to also be clear about what the expectations are going to be in this country for you to be successful. But I need to be able to convey that information to you in a manner that is foremost respectful, not so much sensitive. I don't know if I'm making my point here.
Well, that's very interesting. And do you and in terms of the impact of your work on mainstream institutions and the way they train their professionals, do you think that the kind of work that you're doing is going to influence good practice in hospitals and healthcare clinics in Germany and in the United States?
We have found not only in clinics and health facilities, but also in the educational environment, We had a couple of years ago a situation where we were trying to offer a nurse refresher course, and the director of the program at that particular college spoke to us saying, we have tried to work with these people before, and we know it doesn't work, but let's try it again. So we ran the program, and of the 34 people that went through the program, 33 completed and 33 passed the licensing exam. So this director had to come back to us and to the group to explain why he had said what he had said before, and to accept the fact that with proper support and the necessary guidance, all these individuals were able to succeed in the workplace. So dismissing those myths about incompetence, or dismissing those myths about inability to do, or any of those misconceptions that are so held all over the place, we're showing that it's a perfectly possible and that it's a win-win situation. We get comments all the time for employers that say, for example, that our participants are the ones that always want to take the extra shift, that our participants were so eager to work and look so happy to be able to be back in their profession or to be working in the medical field, that they're the typical employee that works well with others, that the patients always like their approach. So I think that it's really changing minds and changing beliefs.
Very good. And how about, and Ramazan, in Germany, are German health professionals changing the way they, are their communication skills improving? Are they learning, do you think they will learn to work differently or more generously with?
I think I'm working in the field since 22 years, and I see that in the last 5 years there's a really big change in Germany in the view on and in the opinions over the immigrant population. Before 5 years, it was the case that immigration was totally a negative and a bad thing, and the people only realized problems with this subject, and didn't realize the resources they get with migrants in their country. But in the last 5 years, it is one of the 3 most important topics in the political life in Germany, and this is because in Germany, if you look in the 38 biggest cities, then more than 40% of the children younger than 16 have an immigration background. So we have a really cultural change in Germany. You will see in 50 years, when they are 50 or 60, then they have 40% of this group will have the cultural background too. And the policy realizes this reality, and now they begin to stop with being dogmatic and to deal more practical, and to work together with the migrants and to ask them more. So I think we are going to get new power balances between the majority and the immigrant population. If you see, for example, the last 12 years, 61,000 people with Turkish background founded new companies. So if you compare with the Germans, then they have 39% more than Germans who funded new companies. And in the future, this group will create a new society. The society in Germany will be really and deeply a multicultural society. And to deal with health, and we show that to the political sector, to deal with health, to give them the possibilities to participate from the fantastic health services we have in Germany, is a kind of invitation and peace, and is a kind of saying, okay, we have together a future, we are interested in your health, you are invited, you are part of us, you are part of our family, and by health you can give this positive message to the people, and the people are reacting very positive. The migrants are reacting very positive. If you open them the system, they use the system and they are really very thankful, and the reaction is every time very constructive. And in 2 universities of medical schools in Germany, in my own one in Hannover Medical School, and in Gießen, which is a very important university, they began to train the doctors, the students, in cross-cultural healthcare too. So there's really a more professional view on dealing with the health topic and migration.
Thank you. No, that's very impressive. I have a question here from Lucinda Hardwick from Remedy Partnerships in the UK. She writes, I'm interested in how other countries deal with ensuring health access for those who suffered human rights abuses such as torture. In the UK, common access difficulties such as language may be compounded by mental health problems, uncertain legal status, and restrictions on certain migrants accessing free health care. And she's interested in examples of good practice that and asks about a need for better international coordination of good practice in this area. I like to think that, in fact, some of what we're doing today is profiling some of the excellent work that's been done in this area. And I would like to ask both Ramazan and Jose Ramon to perhaps forward to us after the seminar a few examples of the kind of international coordination that already Ramazan has described in terms of the work that he's now doing with his mobility project. Because we have, in fact, come very close to the end of our webinar. We really only have time for one more question, which I'd like to ask. Piali Roy has asked from Toronto, and it's a question about how MIMI grew their program to include financial advice, given that it was outside of their initial area of focus. What led you to step sideways towards this other area of service delivery? Ramazan?
Yes. It was, first of all, it was not our plan, as we funded MIMI and developed the program to be active in the field of financial literacy. But as we dealt with the subject and as we spoke with migrants and we realized that the income of the groups who are participating in our program is lower than the national level. And so we realized that there's more poverty in the group of the immigrants. And we looked for a serious concept, how we can do something about this poverty. And we realized that sometimes they are not planning their financial affairs in a preventive way. They are seeing the next day, the next week, but not the future time in 10 or 20 years, because they are not every time sure that they will stay in this country, and so they are not planning, they have not a seriously financial planning. And because of that, after a little research, we gave them a training how to deal with the private financial affairs, how to plan the future, how to invest in the future, how to deal with money in your former country, because they invested sometimes their less money resources in their former country and not in the country in which they live. And as we organized this program, we were very surprised how much of questions they have in case of the financial sector. They doesn't know how to get a credit, which is a good credit, where you have to invest your money, how you can get the possibilities of the nation. For example, you have the right to get some money for the future every month from your company. So they haven't enough information, like in the health sector too. So it's the same. It's not a difference to have not enough information about health sector, about the financial sector, about the labor market, and so on. And so the questions and the problems are every time the same. And our idea is that you can go in every subject with the same concept, and so the people learn better about every subject and every problem. Because they learn and deal with such a kind of information learning of information.
They really are contagious, these good ideas, and they will travel. I'd be interested very briefly, Jose Ramon, to know whether there's any thought of replicating your model into other professional communities, say engineering or some of the other areas where internationally trained professionals often get stuck when it comes to integrating.
Yes, there has been a lot of interest in expanding our model to include non-health professionals. In fact, we're running a pilot right now at our San Diego center where we're working with engineers. And we work closely with another organization that works with non-health professional immigrants, and we have been talking about this for a while.
That's wonderful. Well, we've come. Thank you so much. Our time has run out, I'm sad to say. So we're going to have to end the session. I'd like to ask both of you one last question, a very brief answer. We'd like to know what the one most important secret is to your success, if you can sum that up in a few words. Ramazan, what's your secret ingredient?
My secret is I believe in the potentials, in the resources of the people who are migrants and of the people who are professionals. I believe in their knowledge and in their resources. And I have respect in which kind the people are very complementary, because in our program we have a focus on the diversity, because we say the difference, the secret is that after our program the people are believing that the difference is a resource, the difference is the best thing we have. The difference is that what migrants are making interesting for the majority, and vice versa.
Thank you. How about you, Jose Ramon, very briefly? What's the secret to your success?
I think the secret to our success is perhaps that we are a very participant-centered model of services, and that means we're completely flexible as to understanding the needs of the people we work with and the people we need to work for. And I would think that that's the key for success.
Thank you.
And a wonderful staff, of course.
Right.
Thank you, and I would like to thank you both for a tremendous session. On behalf of all of our participants, our time has run out, so I will say goodbye. And thank you to Jose Ramon Fernandez Pena, to Ramazan Solman, to Chris Mason, and to our international audience. I ask you to imagine this excellent work being interpreted in your city, adapted by your organization, or changing your neighborhood.